going to interrupt your wonderful conversation because we have another wonderful conversation that we want to make sure that we have plenty of time for. So this session is a panel discussion, group discussion on pediatric advanced care planning. And I have been so excited about this for a long time. I will introduce each one of our 4 panelists, and they'll each have a certain amount of time to respond to some questions. And then they have questions for each other. So we're not going to be opening it up to audience participation. We want to make sure that the full hour is theirs to interact with each other, and you'll learn from that. They will be here afterwards if you want to come up and ask some more questions. So that's kind of our format. I will introduce each one of them and basically start off with this work has been so special. I've been doing adult advanced care planning since I was born, I swear. But in the last 10 years, and the work that I've gotten to do with Dr. Lyon, and then you'll hear the rest, the movement into advanced care planning for adolescents and for parents of children with rare diseases has been heartwarming. It's opened up a whole new chapter and a whole new hole in my heart, perhaps, for the need that exists. So I've really valued the relationship that I have had with each and every one of you. You'll probably recognize Dr. Lyon at this point in time. Again, we started our partnership about 10 years ago, and she'll share with you the work that we've been doing. She's a clinical psychologist at the Center for Translational Science, Division of Adolescent and Young Adult Medicine at the Children's National Medical Center in Washington, D.C. And she is one of the world-renowned champions in doing research in pediatrics. A few years ago, with our work with Dr. Lyon and other work at Gunderson, we developed a pediatric program that we have not rolled out, but we was looking for an organization to help test the implementation of the pediatric strategies. And that's where Essentia Health in Duluth, Minnesota comes in. Dr. Sande and Sandy Carlson both are from Essentia Health. They had been implementing First Steps and Next Steps for years, and were really ideal candidates to move into allow us to test our implementation strategies at their organization. Dr. Sande is an oncologist, director of St. Mary's Medical Center Ethics Program, and director of Advanced Care Planning at Essentia Health in Duluth. And Sandy Carlson is a clinical specialist, director of St. Mary's Hospice, and the program coordinator for advanced care planning, and a key coordinator in the implementation of the pediatric component, and that will really highlight, some of the questions will highlight some of that experience. And last but not least, we are delighted that we have a parent representative, Kate Detwiler, has been an advocate for children with complex diseases for years. She's the mother of 2-year-old Nolan. Kate and her husband Brian adopted Nolan, a blue-eyed strawberry blonde child with a medically complex disease. Kate also works at Children's National, building a primary care medical home for children with medical complexity. And I got introduced to Kate through a new study that Dr. Lyon is going to get funded, right? Related to the replication of the FACE intervention that she'll tell you a little bit about with parents of children with rare diseases. So Sandy Schellinger and I had a chance to go on site and participate in the beta testing for that grant proposal, and that's when I got to meet Kate and her lovely son Nolan. So those are our panelists. And again, I'm going to get started to be able to give them plenty of time to respond. I need the clicker here. So you can take out your poll everywhere, and we'll come back to this question later in the day. Maureen, we'll start with you in terms of what compelled you to want to do research in advanced care planning, in particular with the adolescent population.
So first of all, somebody asked me about what interested me in working with HIV, and actually it wasn't HIV. I love adolescents, and I just happened to come along with completing my degree in psychology just as the HIV epidemic was breaking out with HIV-positive adolescents. So this was 1990, and during that time, many of our patients there were limited drugs available, and then AZT came along, but wasn't the most effective drug. And so what we would see happening, I just recall across the hall from me was the case manager, Keith, and he came to me and he said, Maureen, referring to this young man, he doesn't want to keep doing all of these interventions. So, you know, the physicians at the time wanted to do absolutely everything in as aggressive way as possible, really hoping, you know, the next drug down the line is going to make the difference. But this kid was really suffering. And then I thought, you know, we should ask the teenagers what they want. So we did this big survey in our hospital. And while I'm doing the survey, I'm sitting with this young man who says to me, you know, I told my mother I wanted everything, but I've changed my mind. And when he came to see me, he was actually in a wheelchair, he was losing bodily functioning. And I knew, because the week before I had sat in a case management meeting with our team, that their family was ready to sell their house to pay for the rest of his medical bills. So they were talking about trying to find a shelter for this family. And so then the mom came in afterwards, because I was interviewing first the teen separately, and then the mom. I learned my lesson, that we need to do it together. But anyway, mom comes in, she says he wants everything done. She'd already left her job too, so she could stay home with him. He wants everything done, and we're gonna do everything for him. And you know what, mother wouldn't want to do that. And then I was like, wow, there's a mismatch here. And I went to talk to Carlene, who was a nurse practitioner, was primarily responsible for the care. And I said, Carlene, he doesn't want to keep doing everything. And the tears just started rolling down her face because we get very attached to our patients. We know them for a long time. And so she scheduled a family meeting. They had a talk. He started hospice care. And he actually died within 2 weeks. That's how close to death he was. So that's what got me into advanced care planning. I went home, I talked to my son and my daughter were both in high school. I said, did you know as a teenager you have no legal right to have advanced care planning? And my son, who's never said this before or since, said, I was totally shocked. He's like, and I thought, you know, I'm onto something. This really is not right. So that's how actually I got started. So then, so then I was thinking, you know, there needs to be a better way. So I started talking to all my colleagues in oncology and so on, like, there must be some way to contain the strong feelings and have these conversations. So I'm doing the lit review and I get in contact with Linda, and she says, why reinvent the wheel? And I'm like, what do you mean? I want to do my own thing. And then I'm like, yeah, I don't want to reinvent the wheel. Let's partner together.
Let's collaborate.
Let's collaborate, okay. The theme of the session today. And so we started this wonderful collaboration where we worked with our teenagers who were positive. We worked with a group of bereaved parents and a quilting group and started running different ideas by them to see what would work, what wouldn't. They didn't want to do one session. They said that was too fast. And so we started making different accommodations to meet their needs. And this, in Washington, D.C., was primarily African-American families. And so from there, we developed the FACE protocol. Linda came and did our little beta testing, and I remember one of the young women
and
said,
I was scared to death because I had to do the first, you know, conversations with the children, and I'm like, oh my gosh, but it went so beautifully.
Yeah, and one of them was like, LaTanya, she's like, it was so empowering. Like just the idea you would give them a postcard and they could go ask their doctor a question about their medication or whatever. Yeah. She thought the survey was cold, and she loved respecting choices. Like that was the thing, you know, the intimacy and really caring. So that's how did that answer the question?
You did. And you want to talk a little bit about why it's called FACE?
Oh, you know, I have to tell you that the oncologists were like, these teenagers are not going to talk in front of their families. So when we first did our first pilot study, we said, okay, you can have your parent in the room, or they can not be here, and we'll invite them in later so you can talk first. And with one exception, they all said, it's okay, we can do it with the family in the room. And then the oncology psychologists, like, they're not going to talk. But if you start the conversation first with the adolescent, which is the structure, you start with the patient, because it's patient-centered, and then family, whatever the new word is, not engaged, family-oriented, thank you. that's how we got into, so we actually had a focus group with our teenagers for this community advisory board, all HIV positive, and we said, what do you want for a logo, and what should we call the program? And then FA for family, and CE centered. So we did family-centered pediatric advanced care planning.
And it is our next steps intervention with this population. Maureen has led the publication of many articles related to the research outcomes, and if you haven't taken a look at those, they're stellar, and she's really been a champion to get the word out. What's been some of the obstacles, taboos, and strategies in doing this research?
I think the obstacles to publication, you know, it's like get rejected, do it again.
And
get
not
funded,
obstacles
do
to
it again.
research. She's been, you know,
You have to just be
persevering.
persistent, so
Yeah.
you know, do good work. I think obviously recruitment and enrollment in a dyadic study where you're doing, 12 to 18-month follow-up, and you're working with kids who are poor and families might not be that well educated, that can be a challenge. And that's why I think doing that community-based participatory research from the get-go is really critical. And then we used, at our site anyway, a lot of graduate students, like the two people we have here with us today, Isabella and Chris, because they had flexibility in their schedules. And so when you're trying to get a lot of people together in the same room, we wanted people who could see people at night or on the weekends, that kind of thing. So I think that how do you engage dyads in longitudinal research, I think that was really important, and providing good training people till they're certified and they meet those criteria.
Tell us how you think the adolescents have benefited from the conversations.
Yeah, well, Pediatrics just published our 5-year random outcomes, and we're very excited about that because honestly, you just don't know, you have hopes, you do your pilot. But we found that not only did we, which we expected from all our pilot work, increase congruence. So these families really understood what their teenagers would want. So if they were in the intervention, 3 times more likely to understand. And this was with an active control. We were doing a 3-session intervention. By the way, we used, I'll come back to that later. So anyway, we have high congruence. And then what we found, instead of the intervention affecting symptoms directly, it went through congruence. So if families knew what their kids wanted, those teenagers, a year after the intervention, had significantly fewer HIV-specific symptoms. And this measure of symptoms was developed by the PCATG, which is this, renowned group that had developed this instrument at Harvard years before, so very highly reliable and valid. So we actually had a direct effect on symptoms. There were 11 symptoms in that measure. The 4 most frequently occurring symptoms were sleep, pain-related. So we actually significantly decreased pain in these kids. So you can look that up. It just came out in the latest issue.
And congruence was maintained.
And thank you. And congruence was maintained over time because it's a big debate, right? Should we do early advanced care planning? And if we do, the surrogate's really going to be representing what the patients wanted. And we were able to show we could maintain congruence over a year, even when the kids changed their mind. And we just finished a HIV adult study in the Washington, D.C. area hospitals and had similar findings. They were even stronger.
Yeah, she couldn't rest on doing work with adolescents. She had to move into the adult population.
Well, I thought the teenagers showed the adults how to do it, so I thought that was cool.
Yeah. Thank you, Maureen. I'm showing a slide, a word cloud slide that you shared with me. Do you want to explain?
Yes, so this is from our American Cancer Society funded, the other study, by the way, was funded by National Institute of Nursing Research at NIH. This was an American Cancer Society pilot study, and we've only now looked at the qualitative data from the Respecting Choices interviews. And remind me, is this the adolescent one?
It is.
So this is just overall, what kinds of responses were they giving?
To the hope.
Is this the response to the hope question?
It is.
But anyway, that's one of these word clouds that you get. But you can see that they want their life to be better. We probably should have taken the word think out. They want to get back to normal is a recurring theme. But you can also see that God was important to them and their hopes for a future, going home. But this theme about getting back to normal and religion and spirituality being important to them, we found consistently in our research that we've done. So I've done a lot of work too to see what's the influence of spiritual struggle and spiritual suffering, as well as religiousness on our study outcomes. And we found that all of our quality of life measures were more impacted by religiousness and spirituality than actually by the advanced care planning intervention itself. And I think that's why some of the adult studies have found not a relationship between advanced care planning and quality of life outcomes, and those that didn't find it, because they didn't look to see how much religiousness, the spirituality, and spiritual struggle were moderating variables.
Awesome. Anything that, before we move forward, it's been such a pleasure to partner with you. Anything that has surprised you related to the work that you've done? You think about it.
So
We can
it's not
come
quite
back.
coming to mind.
That's
I guess
okay. That's all right.
Just to comment, I guess maybe it is a surprise to kind of look back and think, oh my God, it took 7 years. You know, it's just if you know that at the beginning, you might not do it. But it's I like this. You might know the Bhagavad Gita. It's this old Hindu text. Yeah. You do the action for the action's sake, regardless of the outcome. So every time I rewrote a grant or got an article back, said, why are you studying HIV kids? If they took their medicine, they wouldn't have this problem. I would just go back and like, okay, just do the action for the action's sake. Say it more clearly, see if I can give them that patient perspective that they actually did value this. And actually maybe one of the surprises is that it did increase adherence, not adherence, their viral load went decreased in our HIV positive teens in this large trial. 3 months out, we lost the effect over time. But their self-reported medication adherence, that was a surprise, went down. So they said they were taking their medicine less, but their viral load was less, which means they had better physical health. And I think what happened is they trusted us more and told the truth, and then we saw the biological outcomes. But I have another theory that I'd love to test, but I won't probably live that long. I think that we enhance their immune functioning by being able to have these authentic, genuine conversations about death and dying, with that being the elephant in the room, and to be able to be treated in a very respectful way as we did it. So,
that's lovely. Thank you. John, what 2 or 3 challenges, maybe 2, that did you encounter in attempting to implement the Pediatric Advanced Care Planning Program at Essentia?
Could I give a little background first?
Sure. You only have 12 minutes, but
Next
you can do whatever
slide,
you want to
please.
with that 12 minutes.
Next slide,
Thank
please.
you. Yep. Perfect.
That's not the slide.
You want that one?
No, I want that one.
I thought you wanted that one.
So, first of all, I want to amend your introduction.
Okay.
I am a recovering oncologist. Otherwise, I wouldn't be doing advanced care planning. One of my mostly respected mentors at Mayo said, oncologists do too much for too long, for too little benefit, at too much cost, for too much suffering. I'm also colored by the fact that my sister, in a former life, was a pediatric bone marrow transplanter. So I have some insight into this world. And she used to tell me stories. I would just go, really? Is that how you do that? Partly driven by the incredible success that pediatric hem-onc doctors have in curing cancer. So our implementation of pediatric ACP at Essentia was a byproduct of our implementation of adult. And could we go back to the facilitators?
Sure.
As you all know, facilitators are very, very key components. So we actually have about 20 next steps facilitators trained for adults. And when we started to think about pediatrics, we thought about, boy, that's a challenging question to decide who is up to the task of doing this for pediatric teens, adolescents. So we are incredibly fortunate. These are our 2 facilitators. The person on the left is Christine Rosso, with her rescue dog. Christine is simply incredible. She's reinvented herself at least once in her life. She's just this incredible social worker. She's done all of our ALS patients and often travels 2 hours across northern Minnesota to do Next Steps ALS. And she said, yeah, I can do that. The person on the right, the baby, that's Marta Maddie. And she wanted the picture with her dad. Marta is married to a nephrologist who's also trained in Next Steps, who also happens to be a vice president of our payer relations. Marta wanted her dad included in her picture because 20 years ago, her dad conducted on his own an advanced care planning discussion with his kids. Next slide.
I'll go back to that, yeah.
So this is called a cairn. It's from Scottish Gaelic. These are all over the place in Duluth. They're meant as a landmark or a guidepost. And Marta wanted me to share this because her father gave her and her siblings guideposts as to how he wanted his end of life to look. So Sandy's going to come back and talk to you about the facilitator experience. So just as way of quick background, Essentia reaches from northwest Wisconsin all the way over into North Dakota. We have 2 critical access hospitals in Idaho. We're doing pediatric advanced care planning in the Twin Ports region, which is Duluth and Superior, Wisconsin. We have a catchment population of about 20,000 pediatric adolescents and adolescents. We have a robust pediatric department with 10 general pediatricians, advanced practitioners, and 11 subspecialties. And when people started to hear about we're doing adult ACP, why do I keep wanting to say ACLS?
It's Bud's fault.
Because that analogy keeps coming up for good reason. Anyway, Erin Grimsby, who's a very talented physiatrist who takes care of a lot of patients with muscular dystrophy and cerebral palsy, said, hey, what about us? And one of our 3 pediatric hem-onc docs trained at St. Jude's who has used Next Steps Respecting Choices. They're also a very forward-looking department managing chronic disease. They actually have a chronic disease management emphasis. They have a pediatric care coordination committee, and we were one of the first organizations in the country to have family and patient advisory councils. We've had that for over 15 to 20 years. So we actually were approached by the pediatricians to start this. In terms of challenges, I think for me, and I'm a 50% guy, I can't even get the analogy. I'm looking at the water glass. Is that half full or half empty? And I think I can't even get past 50%. So I think that means it's half full, right?
Sure.
So I tend to look at the negative. Sandy tends to look at the positive. There was a lot of enthusiasm for this amongst the pediatricians, and we've implemented the program. One of the key challenges, as for all of us, is sustainability. And how do you keep this going in a particular section without standing over their shoulder and reminding them we need to keep having patience? The other, I think, thing that stands out for me is when they approached us and we came back, we went to the Patient and Family Advisory, or Parent and Family Advisory Council, and one of the pretty strong reactions from a parent was, well, that sounds like a good idea, don't do it with our family. Which raised the question of timing. When is this conversation appropriate? So I would say the 2 challenges are sustainability, which is no different from any other kind of advanced care planning. But I do feel like the timing issue in this population is a little bit more challenging than with adults.
Absolutely. Thanks, John. And given the experience now that you've had, you might want to talk a little bit about how many patients have been impacted, but what reactions after the experience, right? We know that experience changes people's attitudes, but what reactions have you received from the PEDS team, physicians, and others since implementation? Yeah,
so it's been really quite positive. I also want to point out that Essentia Health is a hybrid Catholic secular organization. And in Minnesota, that means a lot that you're partially Catholic. You have to pay attention. And so actually the chair of pediatrics is a very devout Catholic. I like him, I respect him. And he had justifiable concerns about, gee, what's the message that you're going to be giving here? And you've heard that before, right, Linda?
Never.
Never. But once he learned the curriculum, saw the questions, he said, yeah, that's really helpful. Mm. So he's been actually an advocate in the department. And actually we've done, 3 or 4 of his patients. And what he's told us is that it reconfirms their team approach. It helps them recognize gaps, and then it helps them close the gaps in terms of communication. I guess another learning is not all pediatricians buy into this, and I would direct this mostly to the subspecialists. Aaron Grimsby is a notable exception, but we've had a challenge getting into our oncology area. It's not that they're necessarily against it, but they feel like they already do it. And in part because of how successful they are. I mean, as an adult oncologist, look at the pediatric oncology world, and I really wish we would have done things the way they do things. Mm-hmm. Most pediatric oncology patients are on study, and that's how they get to 90% overall cure rate for cancers. Mm-hmm. Us adults are maybe 30 or 40% because we don't put people on protocol. We ask really stupid questions for publish or perish type studies. I'm going aside. But especially the peds people, and I learned this from my sister, I don't want to say control in a negative sense, and actually the chair of our pediatric division wrote an opinion piece for the American Society of Clinical Oncology, and it was titled something like, "It Must Be Hard," referring to caring for a pediatric patient at the end of life. It must be hard. Part of that was don't give up too soon.
Mm-hmm. Thanks, John. Appreciate it. Sande, we'll get your perspective, and you have any other things to add to the questions that I asked John, feel free, because you are there every step of the way. But in particular, what differences have you seen in the next steps conversation between the adult experiences and then the pediatric interventions?
Yeah, thanks.
Yeah.
Well, I first want to thank Maureen for doing the work and for Linda, because this really is such important work, and it's so great to have a roadmap, because the first call that I got when I took the job 4 years ago was from the PEDS case manager asking what we were going to do about pediatric advanced care planning. And so it's been great to have that availability. Our conversations have primarily been with parents of children with serious and long-standing, primarily things that they've had since birth. We've had a couple of conversations now where they weren't exactly an adolescent, but they were old enough to be present. We had a 10-year-old and we've had a 12-year-old where they actually were able to be present with their parents. And I think the first difference that our facilitators have named is that they recognize that the knowledge that the parents have about what's going on with their child. A lot of times with adults, we meet and it feels like the first time that the adults have ever heard that they have heart failure or chronic lung disease, or you're really writing down how you're going to refer them back to their primary physician or their cardiologist to get more education. And that was one of the first things, that these parents are very knowledgeable, and they have spent years keeping this child going, keeping this child alive, making decisions all the way along. That so when they are here for this conversation, it's not the first time they're thinking about this. And so I think one of the really great things in working with Linda was we were able to actually get feedback from our parents about some of the questions that were on the SOTP and on the interview tool, such as, the question that we ask in Next Steps is, if you were to suffer from, and they're saying, well, we've already had all that. So we were able to change the questions to make more sense to these parents, because they've been living with this. So that was a big difference, that these aren't new topics for these parents. I think the other thing that our facilitators can name is that a lot of times with adults, we ask what a good day is, and they kind of have to really ponder that for a little bit. And our parents have been very articulate, and even the couple kids that we've talked with have been very articulate about what a good day is. And they've worked with parents of children who are nonverbal, and they can define when they know that their child is having a good day, what that looks like. They're very clear about, and then so as we go on to ask questions, the parent's very clear about what it would look like when that child was no longer to have that good day. And so that's been really interesting and kind of a revelation to our facilitators. And as John said, our facilitators, what we didn't mention was that Marta is also an Episcopalian priest and has spent a lot of time working with adolescents and children. And Christine's other part of her job is been peds rehab, so she also had that pediatric experience. I think that for the most part, our parents have been very articulate, and you can tell they've had to do this for years, talking about their kid and advocating. They're such strong advocates. And so as we have met with them to talk about the next steps, how would you make a decision? What would your goals of care be? They are very thoughtful and sometimes have gone away and come back and had more conversation. I think that the other thing that we've seen are the similarities. They're very grateful for the conversation. I think as John said, when we went to the Parent Advisory Council, so the leaders in PEDS said, this is going to be great. The Parent Advisory Council is going to love this idea. They're all going to be all over this. We went, and they said, it's a great idea, but I want to talk about hope. I don't want to have this conversation. So that was kind of surprising based on what I thought we were walking into.
And then yet you were courageous to go forward anyway.
Right. We had physician support. Our PEDS physiatrist really wanted to make this happen, and our PEDS group, the pediatricians, the general PEDS, said they probably could think of about 20 kids that should have this conversation right now. And so we've been sort of working through that. So the glass half full part is that we're continuing. And what the other key piece has been our care coordinators in PEDS. They came to the training, they understand the program, the process. We worked on workflows together, and they are really strong advocates for advanced care planning for the kids that they know could benefit, and the families. I think that the similarities also are around that balance of hope versus suffering, and how do you walk through that with an adult or a parent of a child, or a child is they feel that same sort of fine line, and a lot of times it's been easier with children to talk about what might be ahead, and part of that is our pediatricians have been, or the PEDS specialists have probably been better about that preparation, but they've had really good conversations about that.
Thanks, Sandy. In listening to the facilitators' experiences, we kept talking with them through implementation, and there were so many amazing stories, but I've asked Sandy to pick one of them that really reflects the experience of the facilitator and the family through these conversations. I don't know, she didn't know how to pick one, but
No, I have
she
a
had
list.
to pick one.
I think the most impactful story, like like we said, every time we do a facilitation, we get together with a facilitator to talk about what their experience was and how things went and what we might need to change. And they're just overwhelmed, and the emotion is just amazing. And we had a 10-year-old with a neuroblastoma, and he had been treated for several years and had been in remission and had his tumor come back and had tried some chemo. And at 10, he had had a conversation with his peds oncologist to say, I don't think I want to do this anymore. And so the peds oncologist, we had just started doing peds ACP, and he made a referral. He said, you know what, I really think this is a good time to have this conversation with this boy and his parents and others in his family to really verify that this is truly what he wants us to stop. And so our facilitator, Marta, did the conversation, and she tells the story. It was really kind of a fun afternoon because his brother was with. And so it was a mix of somber discussion and two boys picking on each other and passing gas. The brother, I think, was around, I don't remember if he was just a little bit older or a little bit younger, but not too far in age. But so you can imagine it was a little bit of chaos, but it was an amazing conversation where this 10-year-old was able to say, if I only have 6 months or 8 months or a year to live, this is what I want to do. And so he wanted to quit school. He had a bucket list, and it was a long bucket list. And so he did. So they had the conversation, they went ahead, over the next 6 or 8 months, he did his bucket list. He actually got somebody from Los Angeles to help him make a movie. He wanted to be in a movie. And so they came to Duluth and had a filming, and he did all this stuff on his bucket list. And I was fortunate to understand when he came to hospice and saw the full circle of him creating this bucket list and doing everything. And he did that bucket list until the day he died. And so it was very, very impactful, I think, to see that full circle.
Thank you so much, Sande. I wish you could tell about the 10 other stories as well. Yeah. I also want to just clarify that she's mentioned 2 pediatric groups. One are the individuals that, has been the subject of Maureen's research, adolescents who can participate in the conversation. The strategies are a bit different than talking with a parent whose child cannot participate, and the parent needs to think about goals and values in light of experiences, et cetera. So we really see all pediatrics are not, the same size or shape, and modifying some of the strategies accordingly. So both of them kind of identified that. Kate, we're going to turn to you. We're really looking forward because, number one, your story, when I got to talk with you, touched me in a way that I didn't think I could be surprised.
She bawled
hardcore. I couldn't help it. And the other thing is, in the beta testing, she was taking care of Nolan, and she was taking care of Nolan, and couldn't come into the clinic, the office. So we said, well, we'll do a video, and. Telemedicine, yeah, but it was video, and it was beautiful. And I, when we met today, and we've talked since then, this is the first time we've actually physically met, but we met through video, and then at the end of the conversation, she brought Nolan in, who was trying to walk, et cetera. So the video interview was beautiful, and it gave us more encouragement that video telemedicine can really work to have really sensitive conversations. So, Kate, how do you think these advanced care planning conversations help parents? Are there ways they do not help parents?
So I come to this space on the peripheral outside. I'm a non-clinician, but I was a part of the pediatric palliative care program at Children's with Debbie LaFawn, who many of you might know, and Conrad Williams. And so I got to see through their work how families who got to have these conversations did and how families who didn't get to have these conversations did. And I saw both sides of it. And when my husband and I decided to accept Nolan as our adoptive placement, I knew that I wanted to be one of those parents that had those conversations, because I saw how some families just kind of thrived with them. But I think that there are maybe two sorts of families, and you talked a little bit about them. Families that think about it all the time, that their child has a life-limiting illness, and then there's families that don't want to think about it at all. And I feel personally that having these conversations, which we did at the beginning, our first conversation around adopting Nolan was, he was in a local NICU. He was intubated on pressors with dopamine. He has short gut. He's lost 90% of his bowel. He had a PICC line. He was on TPN, and they were looking for a placement. And I was like, well, it is my personal belief that children in our society, in our country, in the city that we live in, should not die alone. And while in a professional capacity, it is not appropriate for me to go up to the NICU and take children home, nor is it for you either, just in case you wanted to know. That's why they got that pink code. Was totally appropriate for me to say that we would take this placement, and that it would be appropriate to bring him into our home. And so our very first parenting decision was around goals of care. It was, will we take this child into our home? Yes. Okay. Will we put him on hospice? Yes. And I happen to be very involved in the pediatric hospice community in DC, and I know a lot of the providers, and I knew that we would get good care, and that is in itself a privilege that we enjoy, and I felt that this child should enjoy if his course were to go that way. And so I firmly believe in advanced care planning for this little guy. He's a little bit bigger now from this picture, but that is why I went to Maureen when the R01 for looking at advanced care planning with rare diseases came out, because this needs to be looked at in this heterogeneous population, and we need to look at how we can serve families better that don't have a clear path forward, and we need to look at how we can serve providers better. I think Dr. Sande talked about this. I'm going a little off from your question, but
you just go.
I'm going to keep talking, and you tell me when to stop.
Yeah.
Dr. Sande talked about this. We have a very talented gastroenterologist who is a horrible communicator. She is literally the worst communicator ever. She's mean, she's a bully, and I knew about her reputation before we got care there, and I was like, well, whatever. No provider is gonna go against me being this child's mom and being his advocate, and we've had fights, like unprofessional fights. But you do what you have to do. But I was told that if we were to consult our palliative care program formally, that she would discharge him from service, which we know is unethical, but we also know that it would happen. And so I actually got Dr. Lyons to include her in the research pilot work. And so you can see how I kind of like manipulated the situation. Now, we still don't have a formal palliative care consult, but having opportunities to engage in research, which I think we see in the oncology community as well, are opportunities to change attitudes and behaviors with providers. And I hope that through being a good role model to her as a parent and engaging in these conversations with our pediatrician, which is where I personally believe a lot of advanced care planning for children with rare diseases belongs. Early on, very early, every year, get your flu shot, have your conversation, and move on. I mean, I think it was just transform. I think this work and the opportunity research provides can be transformative in a culture like ours. Sorry, I would totally like.
Don't be
Spewed.
sorry. No, it's awesome. Well, what other experiences have you had with I mean, as you were interested and willing to have the conversations, but have the conversations had any impact on any decisions you have decided to make, your relationship with your husband, Brian?
My husband is an attorney, and we think very differently, but we're very complementary, which is why we've been married for 13 years. No applause. 13 years. I've only been married once, too. Come on. Thank you. Look, it's a challenge some days. As any marriage is, right? Like, marriage is hard work, and when you're 22 and you get married, you don't know that, right? You think like, oh, I go to high school, I go to college, I get married. Like some house appears from somewhere that's fully paid for, and like there's some turkey that shows up every Sunday. But it's not, it's hard work, and parenting is really hard work, and nobody tells you that. And so if you can't have you can't have these conversations when you're in a crisis, because if you're not on the same page, you have to have those conversations slowly in quiet periods of the morning, or when you're walking on a beach, or when your kid's having diarrhea all over the floor. That's when these conversations need to happen, not when your child's in sepsis and you have to make decisions that prepare you, that can impact your life. Because I think that maybe, and you could talk a little bit about this when I'm done, the thing about adults versus children is that you're talking about a family unit that will continue, and it may not, and most of them don't, I think statistically don't survive. And that's the difference. And if you want your marriage to survive, if you want to have an intact family for the rest of your the rest of your children, if you have them, which I don't, then you have to have these conversations, and they're hard, and there can be a lot of disagreement, but the place for disagreement is not in the PICU. And I think families need to understand, and providers need to understand that. Walking into the PICU and thinking you can have this conversation is wildly inappropriate. You should have these conversations with your spouse beforehand so you can get the ugly shit out of the way in the bathroom. Mm-hmm. Sorry, I'm kind of I cuss a lot, sorry. I know. I gotta get parenting advice from her. And what was your other question real fast?
I don't know.
You got to get it out of the way.
No, exactly. No, so I think a couple of things that impressions, like when we were doing the beta testing, Sande, you mentioned that your experience is that these parents are the experts. And when Kate started explaining about Nolan, didn't she sound like a medical expert? Yeah, they're really experts in the care of their child, and that really hit us pretty strongly as well. And then the other concept that I remember from one of the other parents, and if you want to speak to it at all, is the parent said, I live in perpetual grief. Oh my God, that phrase, I just can't let it go. Mm-hmm. It sat with me forever and ever. I live in perpetual grief. Can you speak to any of that, or what else you've learned through having conversations?
I agree with that statement, but I feel like, and I feel that too, but for me, I feel like I am some sort of professional base jumper. I just don't know how deep the canyon is, and I don't know where the walls are, and I don't know when I'm gonna fall. And every fever greater than 100 is a fall, and I don't know what that means, and I don't know what every bout of serious vomiting is, and is this the beginning of the end, or what is this? What's happening? What recourse do we have? And advanced care planning is my parachute in that analogy, because I can hold true that no, we're not going to do that, or no, we're not going to make a rash decision around transplant, because I've had that conversation with Chris Feutner. There's no one else you have that conversation with. And so I really feel like it is more for me falling into a chasm, and then having advanced care planning being my parachute to keep me true north to what my husband and my family believe is in our son's best interest. And if that, it's really important for us that he lives a full life, and that we know what his best day is, and that he lives to that, even if that changes, but that we don't make regrettable decisions in haste or due to provider pressure, which is a real thing.
Do you want to talk more about that? Provider pressure?
She is a trip. I mean, not to get too personal here in this open forum, and please don't share it outside this room of 200 of us. And it's being videoed. Yeah, I want you to save me.
Do you want to say anything to?
You can save me.
We had a Skype conversation, and I recognize what you're feeling. The F word's been mentioned, and I can't remember what you
And
said.
the S word.
S word. So this is my personal opinion. Medical education is bass-ackwards. In my opinion, the only important courses in the first year of medical school were anatomy, physiology, and pharmacology. The rest of it should have been about professionalism. What is it that a doctor does? There was a really good talk yesterday. I'm sorry, I'm forgetting his name. He's a student of Edmund Pellegrino. And Pellegrino was a very prominent Catholic physician and philosopher. And he says the outcome of every clinical encounter is framed by 3 questions. What can be wrong? What can be done? And what should be done? That last question is a moral question every single time, even if you're in urgent care and you're treating a sore throat. And that last question depends on what it means to be a human being. And if you don't know the patient's or the family's or the parents' goals, values, and beliefs, you're going to do a hell of a lot of harm. Nobody teaches us that. We're taught how to make a diagnosis and what the options are, and then basically you kind of choose whatever you want because you're the doctor. That's how I was trained at the world famous 80 miles south of here. I hope it's changing. Yesterday I drove back to Duluth for a second-year medical course in the healer's art, and we talked about awe and mystery last night. So I hope it's changing, but I'm guessing your gastroenterologist is in their 40s or 50s.
But it's not going to change without these efforts, all 4 of you, the efforts that you're making one by one, the getting the gastroenterologist involved in the research, just all these steps. So comments and or questions that you have of each other, we'll open it up.
So I think this is very challenging. If your role as a physician and your identity has to do with saving and finding cures and doing the best treatment possible. Just like these physicians early in the HIV epidemic saying, if we can just wait a little bit longer with cancer, and where do you draw that line? So when I met with this gastroenterologist, we had a lovely discussion. And I have to say, when I've sat down with physicians, I feel like there's a lot of the edge of burnout, of having medications that work that the patients don't take, and just being torn apart by how do we increase adherence. All these things are fairly complicated, and I think they're cultural too. I think in our culture, physicians are actually more likely to be on the same page with the patient than maybe in some other cultures where the physicians is still held in high esteem, and it would be considered disrespectful to bring your card to the appointment and ask questions. And so I think there has been a lot of movement. And in this physician's case, she was talking about the literature showing and this pressure to do transplants, and she said none of the data are reporting the number of children who die after the transplant. They're only measuring quality of life of those who survived. And I went and looked at the literature, and it was true. So she was, so she has her own ideas about things, and she was very concerned about the child's quality of life and feeling very proud of the children. But again, like many of the other physicians I had met with, I'm thinking of somebody who does cystic fibrosis who said, that's not my role, but if you want the social worker to do it, that's okay with me. I think if you can,
Well-
when somebody's telling you they're going home and having many drinks at night because they have this like $1 million drug that will cure this kid's life and he's not taking it, you know, you're having a problem with moral distress in the physicians too. So I think in terms of this collaboration, I think we need to bring everybody in.
Right.
Bring into the tent. When I first started doing this research, we did this science in a fishbowl, and everybody was all over me about why are you doing this? It was myself, a chaplain, and the statistician in the middle. Then a circle of researchers and a circle of people from the community, and we got a lot of pushback. And one of the best things I was told was bring into the tent the person who is most against your research.
Lovely.
So that you could begin to smooth out the rough edges, like a marriage, right? You have a lot of rough edges when you come into marriage. I've been married a long time now, so it's much better.
But can I just acknowledge that? I mean, if we're going to make movement, then we have to understand the other person's perspectives, because that's always been helpful. Because I have been angry at your gastroenterologist. I'm like, it's causing suffering for you. Not only, I mean, and I've been angry, and some of those reactions are just really hard to balance with the good work and then being understanding. So sometimes you need other team members who can move in and help you out. You can't always do it yourself, and so that's, to me, really cool, is we all have different perspectives.
And don't get me wrong, she works very hard, and she's a very good clinician. But in this respect, and this is why, and I think the research in the space in oncology, this is why I believe this work belongs in the pediatrician's office, in your primary care doctors, because there isn't that burden of cure on them. And you have even if it's a trauma, you have a healthy 6-year-old and they fall in a pool or something, you have a relationship with them that you've built over years. And in much more in that case, do I personally think where you as a parent can realize that providers are human and that they have bias and that they have these experiences that may lead them to believe these certain things, and that it really isn't about you and it's not about your child, it's about them. And it can lead you to have some compassion for the other way around. So it's fine that it's not fine, but it's fine. I can only do so much. Get her in an R01, for God's sake. What more do you want me to do? But at the end of the day, I have other team members but I also think that this does belong with a physician or a nurse practitioner, to be honest with you. I have the utmost respect for my social work counterparts and my case manager counterparts, but at least in my child's case, we are making very clinically oriented decisions every step of the way, and they're not more social or cultural. And so I want to make informed clinical choices when I'm reading a paper or we're discussing an intervention, that my goals of care are being taken into consideration around that clinical decision and that clinical intervention.
And we would agree with you that advanced care planning is about making future decisions. Your parachute analogy is beautiful, and there also needs to be a complement of providers who have skills in helping you make current healthcare decisions aligned with the goals and values. We totally agree with you, and there's often a gap in one or the other. A comment?
Well, that's one of the things that has also been different with our peds population, is that the pediatricians that have sent the referrals, I've heard back from just about every one of them every time saying they've read, because we can copy the notes to them, they've read the notes, they appreciate the information, it's going to help them in future conversations. And they've actually said that. Not heard that very often from the adult.
Beautiful, and I remember one of them talking about she was invited then to a team meeting because of her conversation. The team wanted her there as just another example.
Right.
Yeah.
Yeah, she did that, yeah.
Yeah. Well, couldn't we continue this for another hour? So in parting, John has found a beautiful poem that probably summarizes the spirit of this work. We have a long way to go, and with these courageous folks and others who join us, I think we have a lot to learn. So my kudos and ultimate thanks to all four of you.
All right, so I'm going to start with a shameless plug for shared decision-making in serious illness. One of the things we are learning for physicians in particular who learn that curriculum is it wears away all this stuff we accrue over time, and it gets us back to why we really entered the profession. And that is being with patients and families and talking about these crucial things. And I actually made that point last night to 60 second-year medical students, that the very fact that you're in a room talking about these things is itself awe and mystery. So this is a poem. It's really
You might have to read just a little fast, just so you know.
Oh,
Unless you guys don't mind cutting into your break. Is that okay? All right, thanks.
So this is written by Pablo Casals, who actually has a very interesting connection to Duluth. Amit Peled, who's another world-renowned cellist, actually owns Casals Cello. And earlier this year, Peled came to Duluth 100 years, exactly 100 years after Casals was there, played the same recital on the same cello. So I want to dedicate this to parents like Kate, to Linda, who doesn't have a hole in her heart, to Maureen, who is really a pathfinder to make this work possible. And I promised Kate I could make it through this, and I'm not sure I can, but I'm going to give it a shot. Each second we live is a new and unique moment of the universe, a moment that will never be again. And what do we teach our children? We teach them that 2 and 2 make 4, and that Paris is the capital of France. When will we also teach them what they are? You are a marvel. You are unique. In all the years that have passed, there has never been another child like you. Your legs, your arms, your clever fingers, the way you move. You may become a Shakespeare, a Michelangelo, a Beethoven. You have the capacity for anything. Yes, you are a marvel. And when you grow up, can you then harm another who is, like you, a marvel? You must work. We must all work to make the world worthy of its children. That's also relevant to adult advanced care planning.
Thank you, John.
So thank you.
Okay.